Hello, I'm Nathan Carlin. This is Life and Work. Life and Work is a series where we talk to scholars and intellectuals about the connections between their public scholarship and their personal lives. Life and Work is supported by the McGovern Center for Humanities and Ethics. Today we're talking with Dr. Abraham Nussbaum. He's the Chief Education Officer at Denver Health, a professor of psychiatry and assistant dean of graduate medical education at the University of Colorado School of Medicine. Thank you for being here with us today.
Thanks for having me, Professor Carlin. It's a privilege.
Yeah. So our theme, as always, is the relationship between life and work, your life and your work. And so tell us, first of all, how did you get into medicine? What drew you to it?
Yeah, I think we always try to understand life backwards, right? I'm the kind of person who makes a plan and then figures out afterwards that the right thing happened despite my plan. So I grew up in Texas and Colorado, had no real thoughts of being a doctor. It was not really something that crossed my radar.
Oh, really?
Yeah. Some kids go pre-med in preschool, not me.
Yeah. What did you want to do?
I don't really remember at this point. I think all things that I'm not really capable of, right? I think I wanted to be a rock star or drive race cars or something exciting like that.
Yeah.
And instead I became a psychiatrist. Life plays jokes on us.
Yeah.
For me, when I look back, I realized that there was a series of people that I knew in my life who suffered a great deal from mental illness. People in my family, in my neighborhood. There were classmates of mine, even in elementary school, who died by suicide, people who had bipolar disorder, schizophrenia, and really saw their life interrupted. But formally, my memory was that when I was in college, I studied English, Lit, and Religion, which was amazing. There was a classmate who got quite ill, and watching her fall out of the community really gave me something to think about. It became clear to me that that kind of life of the mind community, that cognitive community, had no place for this person when they were ill. And it got me thinking about how we think about the ill in relationship to other people. So I was headed towards grad school in the humanities. I was really excited about it. And I thought, you know what, I need to go see what it's like to be ill. So I spent a year in AmeriCorps on the west side of Chicago working with medically ill and injured homeless people. And I saw how they were not in the world, that they were really exiled from the world because of race, class, and illness. And I would accompany them to medical appointments, and I would see how they were treated by doctors and nurses. And I was really confused by that. But I'm also the kind of person that when I get confused, I read a book about it. So I went to a used bookstore, picked up a copy, went to the section about medical ethics, and I wound up buying 2 books that day at the used bookstore. One was Foucault's Birth of the Clinic.
Oh,
and
wow.
Foucault was dead, and the other was Stanley Hauerwas's Suffering Presence.
Wow.
So I wrote Stanley a letter.
So did you know anything about Hauerwas before that?
I had heard of him, but not really.
Yeah. Uh-huh.
Okay. But I wrote him a letter, and he wrote me back, and he invited me to come work for him for the summer.
That's amazing.
Yeah, I was grateful. He was and is a generous friend and mentor.
Yeah. And so you were at, was it Swarthmore? Is that?
Yeah, I went to Swarthmore, terrific school, pretty nerdy.
Yeah.
Very nerdy school. I studied religion, English, Lit there.
Yeah. And so when did you read Foucault and Hauerwas again? This was?
I read in 1998, the year after finishing Swarthmore.
After college?
After college,
okay.
I was doing AmeriCorps.
Wow.
And I went to Pal's bookstore in Chicago.
Yeah.
Great bookstore. And, picked up a copy of both of them.
Yeah.
And they kind of blew my mind.
Yeah.
Right?
Uh-huh.
And they were very different than what I was seeing. And in some real way, some version of those 2 arguments are the kind of arguments I've been tacking between for the rest of my life.
Interesting. Yeah. Okay. So then you write Hauerwas a letter. You then go work for him?
He was very kind. He found me a place to live for the summer.
This is at Duke.
Yes, sir.
Duke. Yeah.
Yeah, Duke Divinity School. And he said, I need somebody to put together a reader of my material. To be clear, there were editors, former graduate students of his, who were putting it together, but I was the grunt, the person on the ground, transcribing them, collecting them, putting them into documents.
This is that giant Hauerwas reader?
Yeah.
You were involved with that?
Yeah.
Really?
Yeah.
Okay.
Stanley had an early generation word processor. They were kind of locked in. Some of the documents were locked in. Some of them, they were only available printed copies. And this is lost on many of your readers, but you'd have to scan them in and then convert them to a Word document, clean them up, these kinds of things, and then prepare them for the editors of the book.
Yeah.
So I did that for the summer, and Stanley was incredibly generous to me because he said, I'm paying you for this work, but I really want you to learn some things. And so he assigned me books to read. And then he would generously, even though I was not a student of his, he would meet with me and talk to me about the books I was reading. They were books he'd read a million times before, but for me, it opened all kinds of doors because I couldn't see how you could synthesize something like Foucault with something like Stanley Hauerwas. And he was able to see that synthesis, right? And that was the incredible gift of that relationship.
So then what happens?
Well, what I tell people, and some version of this is what happened, is that I told Stanley, I said, look, I've had this experience of seeing sick people, but what I think I'm good at is this kind of cognitive work of English lit and kind of philosophy and theology stuff. I'm thinking about becoming a bioethicist. And Stanley said to me, he said, bioethicists are assholes because they tell people what to do, but they don't do it themselves.
Yeah.
And, I was like, huh. So Stanley said, if you want to do this work, you probably should go back to med school. And I didn't have any of the requirements you have to do. And so I had to go back and do what's called a post-bac program. I did that at a terrific liberal arts school called Bryn Mawr. Go back and take all of the chemistry stuff you did. So when you do 1 year, you do all of the pre-med requirements, and you take the MCAT. It was kind of a horrible year in my life. You didn't do much more than study. But it was a great school, and I did that for a year. And then I went back to Duke, worked for a year, and then wound up going to med school.
So you went to med school because of Stanley Hauerwas? In
a real way, yes, but also because of the people I'd met along the way and those experiences. But yeah, Stanley was incredibly important in it.
Yeah. And back to your days at college when you said the young woman that fell ill, was that a medical illness or psychiatric illness?
Yeah, it was a medical illness.
It was a medical illness.
She had to take a year off of school.
Yeah.
And she was a very, very bright and accomplished young woman. And it was clear that there was terrific things about an intellectual community, but there were profound limits if it couldn't include the sick. Because part of what it means to be human is that we are vulnerable to illness and then fall ill ourselves. And any community worth really being a part of has to have an account of what it does with people when they're sick. And I was worried that a purely intellectual community couldn't account for her. And then, therefore, couldn't account for the rest of us, because we would all be sick at some point.
Yeah. That something seems right about that, yeah.
I'm pretty sure that we should all assume that we are vulnerable to illness, right?
Yeah, but I mean, even just the critique of academic culture, right?
Yeah. What do you do when somebody has sickness? Is something that any society needs to think about.
Yeah.
Right? And how we're going to care for each other in our sickness. And so that experience, again, I loved so many things about my alma mater, but that worried me.
Yeah.
And that gave me pause about going straight into the academy, right? I was always good at school, and a kid who liked to read, so it kind of made sense to go from a school like Swarthmore to get your doctorate in the humanities. But something didn't sit right. The other thing that didn't sit right was that something was wrong with our broader community when I saw the way that people who were medically ill and homeless in Chicago also were out of the community.
Yeah.
And so, those are the kinds of questions that I've spent the rest of my year, the rest of my life, thinking about and working on in various different ways.
And a desire to help these people that are being pushed out or ignored, marginalized, or whatever.
Yeah, I guess I would just say, as a human being who himself is vulnerable to affliction, I want to be a part of making a world that takes care of people.
Yeah.
Right?
Yeah.
And I think the people who need the most care are those at the margins.
Right.
Right? And so, in various ways, those are the kinds of things that I try to do every day.
Yeah. And so what was medical school like for you then? So then you found a new vision or a new calling.
Oh, no.
You go to...
I think that's not what medical school was, right? Medical school was so different because it was not about discovering something. It was about learning material that had already been discovered, right? And when you go to a small liberal arts school, there's a kind of lavish attention to your own thoughts.
Mm-hmm.
That can be indulgence, but also is a great gift where somebody says, I want to know what you think about the text.
Yeah.
That's not what med school was like. Med school is not like, I want to know what you think about the pancreas.
Yeah.
Tell me what you think about lymphocytes. That's not the way med school works. Med school says, we're going to present a lot of information to you, and then you need to be able to synthesize it and feed it back to us.
Yeah.
So I went from a world where I was either, really spending a lot of time reading and then writing essays, or directly caring for people with illness, towards a world where I was really reading large volumes of material and then trying to repeat it back on multiple choice tests. And so I guess I would say I was not a good med student.
Yeah.
Right? It was not what I was prepared for, and it was not what I was skilled at. There were so many of my classmates who were much smarter than I. And one of them I was fortunate enough to marry. So there's some good things about med school.
So along the way, question whether you were going in the right direction, or did it just feel like, well, I just need to get through this, and I know I'm going the right way, and I'm going to be satisfied once I get through this?
I'm stubborn. Sometimes people ask what you need to get through med school, and I'll tell them it helps to be healthy, and it helps to have enough, the ability to either borrow or have enough money to go through. But I'll also say, if they're willing to hear me be a little bit coarse, that you need a trucker's butt. You kind of have to sit and grind it out.
Yeah.
That being said, I thought about quitting most every day for the first several years.
Yeah. But because you didn't have the freedom that you had at Swarthmore, like that, just the intellectual freedom, kind of, or
it wasn't the freedom; it was the lack of agency.
The lack of agency.
And I think that's what a lot of people in medicine, both in training and in practice, struggle with. Mm-hmm. Is it's not freedom per se; it's the ability to affect change in their world. Mm-hmm. And so that was a shock. It was also, it was that loss of agency. It was also the distance between medical training and what I thought I was going to do, right? I thought I was going to be caring for the sick, and I thought I was going to be thinking about these questions about how we as a community care for each other. But on a day-to-day basis, that's not what I was doing, right? On a day-to-day basis, there was a culture, which I think is common to a lot of med schools, of a lot of really talented young people striving to do well on exams. And I didn't, on the one hand, I fit into that in certain respects, and in other respects, it just felt to me like I'd landed on Mars. Mm. And so the good news, I would say, is that I'm sitting here in the McGovern Center at Carolina, where I was fortunate to go to med school. There was a place like this, too. And it, in some ways, really saved my career as a physician to have a group of people who cared about these questions: medical humanities, medical ethicists, medical historians, medical economists, people who had this larger set of intellectual tools to ask themselves, what does it mean to fall sick and to care for the sick? And those were the folks that every time I was with them, I knew why I was in med school. The biochemistry professor didn't quite know why I was in med school. He was a little unclear that I should have been admitted, but Dr. Houle admitted me to the med school, and I've always been grateful.
Yeah. So you're going through med school. How did you decide on psychiatry? Was that clear at the beginning, or did you go through rotations? How did you come to that?
Oh, man, not at all, right? I told you that as far as I can tell, I make a lot of plans, I spend time thinking them, and then life happens, and it's totally otherwise.
Yeah.
Year before med school, I wrote a paper, first thing I ever really published, book chapter, arguing that psychiatry is a form of social control. That's the Foucault side of me, right?
Yeah.
And then I went to med school thinking I would do anything other than psychiatry. I'd read Foucault, and I thought, you gotta avoid biomedicine as a form of social control. Which I didn't really know what that meant, but what I thought it meant was that you had to do something that was clearly and unambiguously a medical illness, and you had to engage with people in that way. So in my mind, that meant oncology, right? Cancer. People have cancer. It's a discrete thing. It's not normal, and you go and you try to reverse cancer. Or I thought it'd be trauma surgery, right? People have an appendix, it's ruptured. They have the aorta's broken, there's a knife in it. I thought that was what medicine was. And I did those rotations, and they were awesome. Amazing people. For about 2 weeks. And then I'd be on them for 2 months, and I would realize that I didn't want to engage with people in the way that they did. A lot of terrific oncologists, but a lot of them were more interested in thinking about the cell biology part of it than the patient part of it. A lot of terrific trauma surgeons, but the ones I liked the most often had become interested in public health. They were interested in how they could prevent people from winding up in the emergency department in the first place. But meanwhile, I knew I wasn't going to do psychiatry. I was confident of it. I was so confident that we scheduled our wedding as med students right after the psychiatry rotation of med school, because people told us psychiatry didn't matter, it wasn't real medicine, you could take it easy on the rotation. So I planned to do anything other than psychiatry. I planned to do poorly on the rotation, thinking that medicine or surgery was for me. And then I got to my psychiatry rotation, and I actually sat down with a person with a serious mental illness. And he was a young man who'd had a trauma, which I thought that was the interesting part of him. And what was actually interesting about him was why he'd had the trauma. And he had become manic with psychosis, we would say, and had subsequently engaged in a risky activity that had caused the trauma. And that he was so ill from that experience that the surgeons couldn't operate on him. And so they'd send him to us to get him well. And he had a book with him, and he would write in the book, and the first line would make sense, and then every line after would make progressively less and less sense. And then we gave him lithium. And watching as his writing started to become more and more purposeful and intent, I realized that it was everything I ever wanted. Psychiatry had a sense of service. It brought people back into the community when it worked. It was a place where the medicine was unclear, where there was lots of intellectual work still to do, and it was needed in the community. And I realized that's what I wanted to do. Now, when I told my classmates that I was going into psychiatry, they all laughed. They're like, "We all knew you were going into psych."
They said that?
They did. They said psychiatrists are the kinds of people who like to ask the kinds of questions you always like to ask in lecture.
Yeah, they
right?
knew. Yeah.
But I didn't see it. They were smarter than me. They still are.
Yeah. So faith is a big part of your life as well. Is that fair? Fair to say?
I hope so. I pray so.
Yeah. Yeah. How do you feel like faith has impacted this journey?
Yeah, great question. Thanks so much for asking. So I'm the oldest of 5 kids from a German Catholic family, and so it's always been a part of my life. I've always been interested in the question about how people organize themselves together and towards their account of what the world's about and the life beyond this world, or the potential of a life after this life. It's what I was birthed into, and I'm grateful for. So I think about it in lots of different ways. For me, that desire to serve other people and to be up in community with them comes directly out of my own faith experience, of being in a community which is increasingly rare, that isn't just organized by class or race or cognitive ability, but really welcomes people from all kinds of things, including sick people. And for me, particularly as a Catholic social teaching, Matthew 25, all of those put the work of taking care of the sick, which is not necessarily at all the same thing of contemporary practice of medicine, but the work of caring for the sick as a kind of divine gift. And that's always been something I've believed in and on my best days practice.
Mm-hmm, mm-hmm, mm-hmm. And do you feel so? Well, back to the whenever you kind of picked up Hauerwas in the bookstore. So he's not Catholic. How did what was it like to sort of read Hauerwas, or are there other Catholic thinkers that you put him in conversation with, or how does he fit in to your intellectual formation that way, or did it matter? Did it just not matter at all? Did he,
I think a lot of times when people think about Catholicism, they think about this kind of all-encompassing institutional church, like a medieval culture,
mm-hmm.
or growing up in a Catholic ghetto. I've really never lived in that, mm-hmm. in the sense that I grew up in Amarillo, Texas,
Yeah.
some time in Austin, Colorado Springs, now Denver. They're all places where Catholics are far and away the minority, and they're not a Catholic culture. When I go and visit countries like Mexico or Italy or Ireland, you can feel what it's like to live in a fully Catholic culture. I've never really done that.
Interesting.
My time in Chicago was the closest. I've always experienced being a Catholic as kind of a minority stance in the world.
Huh.
So it was not uncommon for me to engage Stanley.
Yeah.
And I think part of it is to say that you can have lots of different partners and friends and construct from them a through line, right? And there's a great deal about Stanley's work that is deeply challenging to Catholicism, particularly his interest in Anabaptism. But there's also a great deal of it that's very sympathetic to Catholicism. And so Stanley never, in my encounters with him, ever did anything to discourage me from being a Catholic. He believed, and I think he delivered on, that our conversations and his teaching was to help me be better at it.
Right. Yeah.
I never experienced him as discouraging that in any way.
Yeah. Yeah. So how do you feel like your faith life and your work as a psychiatrist sort of fit together? And I guess the reason I ask that is that different people think about the relationship between psychology and theology in sort of different ways, and sometimes people are skeptical of psychology. They think that it's a secularizing force, or it provides sort of alternative worldly values in place of virtue, Christian virtue, or something like that, or it's too permissive, it's too forgiving. What we once called sin becomes medical illness, or just accepted. So there's just a large theological camp that's very skeptical of psychology and psychiatry. So I'm just curious as to how you, as a psychiatrist and as a Christian, as a Catholic Christian, put these things together in your own life.
When it was time for me to learn how to mow the lawn, my father made me take apart the lawnmower because he wanted me to understand how the tool works and what the tool can and can't do. And I guess I would say that medicine broadly, and certainly my own specialty of psychiatry, is a gift, and it's a tool, and you have to know the limits of your tool. I don't believe that psychiatry should be a way to understand everything about the human person. I don't think it has that capacity. I don't think it has a capacity to say what happens after this life, right? I don't think it's the only way to account for the self, but I do think it's a very valuable tool, right? But you have to know the limits of the tool. So I would say that, all the time I'm going to recommend therapy and medications to people, including people that I love, people in my own family, my friends. But it's not to say that that's an exclusion to other ways of engaging themselves, right, and to understanding them in the world. And I actually think most people believe this. So in the same way that if you go to a doctor and you have diabetes and they recommend a medication to you, but they also recommend some sort of physical activity or exercise, those are different ways of being in the world, right? And similarly, you want to engage in psychiatry, but also a faith community, right? There's just a different benefit of those kinds of things and approaches. So I know that there's a lot of people who see them as necessarily opposed, and I don't. I believe that they are both interesting ways of engaging the world and of engaging ourselves, and they both have different limits. Psychiatry is a problem, like most medical specialties, to the extent that it is taken on its own. One of my professors in divinity school said that if you look at classic Christian heresies, it wasn't that they were wrong, it was that they were a truth isolated from other truths. And I guess that's the way that I think about this too, is that if a heresy is one idea that isn't in relationship to other ideas, Psychiatry becomes a problem when it's the only way of thinking about the self and the human person.
Interesting, yeah.
And I would say that even from a non-faith, even if I had a non-faith perspective.
Yeah.
One of the challenges, I love my specialty. I'm deeply grateful to be a psychiatrist because of the people who have mental illness that I get to meet as patients, and because of the people who gather around them about their care. But there's clear problems with institutional psychiatry. And I think people know this, right? One of them is that it's difficult to access a psychiatrist. Many of that care is really outside of other kinds of medical care. There's still stigma attached to that. Psychiatry, in my mind, despite all of its strengths, is limited because it focuses on the individual person and not on a public health perspective approach to mental health, right? So I think that's, a lot of psychiatrists might agree with me about that, that we focus too much on the individual person and not on the community that they're in. And that's another place where you could say, even apart from a faith perspective, psychiatry has deep limits when it's a tool on its own. It needs to be engaged with these other ways of thinking about the person in a community.
And do you feel like the flip side is true as well, that theology is a useful tool as well, and it has limits?
Yeah, I mean, the statement is that theology is the queen of the sciences. So it certainly has limits. Its limits are much broader, right? Theology makes claims about the nature of the universe, the person, and I accept those, right, as a person of faith, right, and celebrate them. And so it has different limits. But I don't think that, for example, engaging that it's always the right thing to do a theological approach to mental illness.
You said you do not.
I do not.
Right. Yeah.
Right? I mean, in the sense that I don't think, people will use these kinds of cliches like pray it away. I never use that kind of language. I don't think that's the case. I don't think that's how it works. I believe that we have answered the question of, can a person of faith make recourse of secular medicine? And the answer, I think, is yes. The question is just understanding its limits.
Yeah.
And what it's in service of.
Yeah.
Right? It's not just to restore us to function. It's really meant to restore us to right relationship with each other. Right?
And if just as a hypothetical example, if we had, say, a patient come into your psychiatric hospital, and he said he was demon possessed, and how would you handle that? Would you handle that? Would the assumption be this is psychosis, maybe schizophrenia or something like that? We need Haldol or something, or do we bring the priest in to do an exorcism? Do we do both? Like, what do we do with demon possession?
Yeah, great question. Thanks for asking. What I tell med students all the time is that part of the challenge, part of the stance of the psychiatrist is to be aligned with the patient, not necessarily their interpretation of something. So the first thing that you do is you listen. You find out more, right? So a patient comes in and says they're possessed by demons. Okay, I hold that open as a possibility. I also hold open the possibility that it's psychosis, that it's malingering, that it's depression, right? That it is too high of a dose of steroids, right? Whatever it is. I keep a broad differential. Right, I'm not going to commit to a person's interpretation in that moment. Right, being a psychiatrist isn't like having a friend who affirms everything you say. It means that you're going to say, "I hear you. I want to know more. Tell me why you believe that." So, we have had patients who have made statements like that, and then subsequently, we call their family, we call their friends, and they say this isn't who they normally are. And that helps us understand that this is really an alteration. Why is it an alteration? Oftentimes, not always, it is because of a psychiatric illness, and we treat them accordingly. There are other times when we say to people, hey, make that kind of calls, and this person says, no, that's actually pretty consistent with their worldview. They believe in a religious faith, whether Christian or other, that really talks about demons. And then we'll say, can this person go and attend worship services with other people in this state, right? So I take care of patients sometimes who are, what's the right example? I've had Muslim patients who've talked about that, right? And we've had their imam come in and take care of them and participate with them. And that's super helpful in part because culturally specific care is always helpful, because it helps to see the person more broadly, but also because they can help you say, look, this really is pretty consistent with what we believe as a community, or this is not, right? And that helps us.
Yeah. And when the imam came in, I mean, do you also use medication too, or does the imam, or is that just situation specific as well?
It's situation specific. In that case, we did, right? In that case, it took both.
It took
both the cultural engagement and medication to help the person get back to health. But the goal is to say, it's not that I don't believe that as a psychiatrist, that I have an ability to call people to my particular faith, even though that is the faith that I'm grateful to be a member of. I do believe it is my job to serve those people and help to restore them to the relationships that are constituent of their meaning in life. So I would never and have never tried to proselytize my patients, but I do try to re-engage them with the people that are meaningful to them. I also hold out the hope that just like anybody else, people with mental illness can make changes in their life, and they can decide I was raised Catholic and wish to become a Muslim, or whatever other possibilities they are. In my particular clinical setting, inpatient psychiatry, it's usually not the big time to make those kinds of big life choices, right? But in an outpatient setting, that might be something that I would have helped somebody do.
Right, yeah.
To kind of navigate those kind of changes. People get to make changes, right? People have agency.
Yes, yeah.
And as a psychiatrist, you want to encourage it.
Yeah, and people maybe, yeah, well, I don't know if this is right or not. I was going to say that, people want to grow. Maybe they don't. Maybe sometimes they do. I don't know.
What I teach med students, right, is that most of us defend against change.
Yeah.
We're systems designed to defend against change. And so there are only certain times we want to. I've got one joke. Can I tell you my one joke?
Yeah.
Okay, Professor Carlin, here's my one joke. How many psychiatrists does it take to change a light bulb?
I don't know.
One, but the light bulb has to want to change. Right?
That's pretty good.
And so most people don't want to make a change.
Yeah.
So part of our job is to either be ready when somebody wants to make a change, or to help lay the groundwork so they're ready to do that change.
Yeah.
So things like motivational interviewing are about saying, hey, okay, how can I help you move towards a change you need to make in your life?
Yeah. Oh, that's good. That's good. You have a couple other aspects of your professional identity that I want to cover. One is you're a very prolific writer. You've written a number of books. Why don't you tell us about your first book and what it is and how you got interested in it and writing in general. How did you get interested in writing in general?
Yeah, thanks so much for asking. It's been one of the great privileges of the last 10 years is that I've been able to write more. And I think on some level I always wanted to write, but was afraid to say it, like a lot of people. And there was really a time in my life when I wrote nothing. It was a busy time. I was becoming a doctor, and medical training requires a lot of your attention. At the same time, I had gotten married to a terrific person, still am, and she was also becoming a physician, and then we had kids. So there really wasn't time.
That's busy. That's busy.
It's a busy life. It was great, but it was a busy time. I'm glad to have done it when I was younger. At the same time, in my mind, the same questions that I'd always had were there. What does it mean to be sick? What does it mean to care for the sick? What does it mean to be a community capable of caring for the sick? And the great thing about medical training and practice is that you hear a ton of stories. The hardest part about that medical training today is that people don't necessarily have a way to narrate those stories into a larger story. And I just...
As a patient or as the provider?
Both, right?
Yeah.
I think it's really amazing to be the person that somebody comes to with these really hard stories. One of the great things about being a doctor is that people don't come into my hospital and say, "Doctor, I don't know if I should use cloth napkins or paper napkins. Right? Should I go with the yellow wallpaper or the blue?" It doesn't matter. Those are aesthetic, small choices in life. They come to you with big questions. Should I remain alive? Am I myself or am I mentally ill? Am I psychotic? These are the questions people come with. And throughout medicine, people come to doctors and nurses and other clinicians with really big questions. They don't ask about what kind of napkins to use. But then there's not a place for a physician or other clinician to really necessarily do something with these stories. So for me, I was interested in this question about 15 years ago about why some people couldn't stay in the profession, why some people left.
Mm-hmm.
Even some people who were really skilled, people who were good at it. And I had an opportunity at the University of Chicago, terrific program run by Carlin and Dan Solmese, to really think through that question. Why do people leave the profession? People often talk about that as burnout. They, at the time, Far and Dan, talked about it as alienation. People have subsequently talked about it as moral injury, as trauma. Personally, I like to think about it as disenchantment, that there's something where the magic has been worn away in medicine. You can hear my Max Weber coming
Yeah,
through
you
when I
quote
say
him
that.
quite a bit. Was it in your theological education he's important to you, or why is Weber so important
No,
to you?
Weber was important to me, actually not as part of my theological
No.
education.
Uh-huh.
It was because of something like this, where somebody asked me to come to town and they asked me to read some Weber.
Oh,
And it got me reading Weber, and he's one of those people who you've always kind of heard about but never read.
yeah.
And they asked me to read the Vocation series,
Uh-huh.
and they were really helpful to me. And I'm a nerd, so I wrote a paper about it, and then I included it in the book.
Yeah.
And so the work of Dan and Farr, though, really gave me that opportunity to think and read about other physicians.
Mm.
My first book came out because I had some time in that grant to read a bunch of memoirs by clinicians,
Mm-hmm.
and then to reflect upon my own training and experience. And that taught me how to write a book.
Oh, wow.
It was a great experience.
Yeah.
I'm super grateful for it.
It was reading other doctor writers that you became a doctor writer.
Yeah,
Yeah.
right? Which is a very Swarthmore kind of thing to do. But yes, that's right.
Yeah. Okay.
So my first book, in some ways, is about my becoming a doctor, but is also about it's also a book about physician memoirs in its own way.
Yeah. And so the title is called The Finest Traditions of My Calling. Calling is kind of a hot topic these days. You know, the past year or 2 years, residents are really pushing back on that term, calling and vocation and things like that. How do you feel about that discussion? What I hear them saying, and there's a couple of articles I saw, they say something like, "Don't tell me medicine is a calling or a vocation. That's just a way to get me to accept these brutal work conditions, and I'm not doing it. Medicine is a job. Don't come to me with that anymore." You know, how do you respond to that? Do you still like the word calling, or are the residents wrong, or where do you come down?
Well, I wanted to call the book Ideas of the Shipwrecked, and the publisher said no, and then I wanted to call it Attending,
Uh-huh.
and I had this image of a physician's coat that was kind of inhabited by a ghost. And the publisher said, we looked into that, but in the British market, nobody uses the language attending.
Oh, they don't.
So we said, let's find something else, and so we found these lines from the Hippocratic Oath,
Uh-huh.
that I may long practice my craft, and the finest tradition is my calling, and that may I experience the joy of being a physician.
Uh-huh.
And so the joy is implicit in that title for me,
Yeah.
because I would say that the language of calling, many people, if you read Weber, have some sense that it's been worn out,
Yeah.
and that it's used for capitalist purposes, right? And that's what Weber is so helpful at seeing.
In a way, that's exactly what the residents are saying.
Correct. They have a sense that on some level they're making a Weberian argument.
Yeah.
Except they're not making the full Weberian argument. Because what Weber, who's an atheist, is saying is, yes, the language of calling is a religious language that's been worn thin by capitalism, and yet it's the best language we have to explain why you should do this kind of work.
Mm.
And they don't want to make that next step.
Mm.
If they don't make that step, if this becomes just a job, then we should expect to be treated just as a job. So it becomes hard for what I don't think residents see is that if it's not a calling, if it's just a job, then why do physicians have all of the other rights and privileges that society grants us?
Mm.
And I think that's part of why you see that language, that argument being made by trainees more than you see it being made by physicians.
Uh-huh.
Because physicians are on the other side of it, and they're saying, look, I realized there is a reason for this.
Yeah.
But trainees don't, because they don't have many of the privileges, or they don't see them as privileges.
Yeah.
They don't recognize that walking into the room of another person and asking them questions or performing procedures on them, and the patient displaying their body or answering their questions honestly, isn't a kind of privilege. So I want to say that I'm deeply sympathetic with people who say it is not a calling. if what they mean by that is it's not a calling in the sense that I don't have to, I may or may not have the religious component of that language. If they're saying, I'm worried that that calling is being used against me by a large healthcare organization that is really in it for their own profit. I have deep concerns, though, about how the profession survives if it's not something like a calling. And I have deep concerns that it's not a full understanding of what it could be to be a calling, which is particularly that there is a joy in taking care of the sick and being the one who has a gift to give of caring for others.
That's good. That's really helpful. Yeah, and that's a very nuanced response to that. I like that. Yeah, I think you should write that up.
Yeah, I probably should at some point. It's hard to find time to write it all up, right?
Yeah.
In part because medicine is a busy life. It's a full life.
Yeah.
And, I don't know how much the world needs to hear more from me, but I'm grateful every time I do get a chance to publish something. I like writing on books, and I think one of the things I learned from this is that medicine does, I think, for many of us today, lack a sense of organization, a sense of how the story ends. And one of the gifts of being able to write is that it allows you to shepherd your attention and organize your experiences so that they have some sort of meaning. And one of the things I've figured out in my own career is that in hindsight, because that's how I tend to work, I realize that usually after I've published a book, it leads to some big change in my life. And it's in part, I think, because emotionally, mentally, you're preparing yourself to make that change because you kind of gather your thoughts about something, right? So this book, the first book I wrote, was really kind of the culmination and the end of my life working as a full-time inpatient psychiatrist. And the second book that you have on your bookshelf right here was really after several years of working hard in medical education. And so, yeah, it's been really interesting to kind of engage each of these worlds and have a chance to organize your thoughts about them.
Well, yeah. Well, why don't we talk about that? This is you have a brand new book out, just came out a few months ago. Progress Notes. Yeah. Where did the idea come from, and can you tell us about it?
Yeah. I'll put it this way, right? One way that I like to think about things, I'm a huge music nerd, and I like to think about some of like the textbook I've written as like a studio album, right? Where I'm playing along to somebody else. I think about my first book as kind of my indie rock record, where I'm talking about some of the things that are wrong with medicine.
Yeah.
And Progress Notes was an attempt to write a pop song. It was my attempt to write about what works in medicine.
Interesting.
I think a lot of people talk about what goes wrong in medicine.
Yeah.
And that's weird to me, because on the other hand, there's so many people, incredible, smart, young people who want to go into medicine, and yet most of what physicians are writing about is what's wrong with it. So I wanted to tell a story about what works in medicine. And I met a physician named Jennifer Adams, who's featured in the book. She's a terrific general internist and medical educator, and she really believed she'd found something. And I didn't, right? I was skeptical. Like a lot of doctors, I'm wedded to the ways that I was trained, and she really thought that she had found a different and better way to train people. And I started listening to what she had to say, and I started to follow her, and I started following her students, and I was really impressed. They were doing the things that I want physicians to do, and I think we all do. They were seeing patients irrespective of their ability to pay. They were seeing them in every setting, including their home. They were getting to learn them and what was wrong with their body. And I realized in doing it that it was a kind of hope for the future of medicine. And that's what I wanted to write about. I wanted to write a story about what works in medicine. For me, one of the great unmakings and remakings of my life was medical training. I truly believe it was a transformative experience that changed me. And so I wanted to write about that and write about a way to do it even better through these experiences of these 7 med students. And I'm deeply grateful that they allowed me to share some aspect of their life.
Yeah. So, I mean, so in the first book, in a way, it sounds like you're getting back to Weber, you're saying it's about the things that are wrong with medicine, kind of disenchantment or something. And so in the new one, is it fair to say that this is enchantment or something? Or?
Yeah, that's right. I think that's fair, right?
Yeah.
So in the first book, I'm critical of some of the things like quality improvement or wellness initiatives that people have tried to fix medicine. And in Progress Notes, I get to celebrate something that works, right? One of the things I talk about in here is that I think that what Dr. Adams and other educators like her doing is what I call a 2 textbook approach. If you think about the way that I was trained, and most physicians are trained, I say we were trained on what I call a textbook of the body approach, where the key thing was to learn how the body works and doesn't work, how to take it apart, how to fix it. That there's really this kind of inorganic metaphor, really mechanistic in that work, right? And I think that's part of what reduces physician agency, leads to disenchantment. And what she's doing here is what I call a two-textbook approach, where you're learning both the body. You certainly want a physician to know how the pancreas works and doesn't work. But also you learn the textbook of the community. You're really learning people as people, and you learn how they stick themselves in the world, to use Walker Percy's phrase.
What about your writing in the future? I think you mentioned to me in a conversation before, you're writing a novel. Is that right?
I am, yeah. I mean, yeah. I guess if you ask me that question about writing my future, the answer is yes.
Yeah.
I'm grateful every time I get a chance to write, and want to keep doing it as long as I can. For me, one of the questions is about how you can fully understand another person and also write about them, right? And there are terrific things you can do in nonfiction, but there are also limits to that, right? Especially because so much of what, as a physician, I'm privileged to learn about other people is confidential. I think physicians have underestimated how much physician writing is unethical, and how the ways that physicians tell stories about their patients and their trainees is more problematic than they account for.
You feel uncomfortable with it?
I do. I think, my first book was written retrospectively, and so there's a lot in there about people I had met as patients, and I didn't, and then after that book was published, I would go and see patients, and I knew I wanted to write a book, and I became concerned. There was no way that I could ethically consent a patient who was held often against their will in a psychiatric hospital to write a book about them. And I think that problem is maybe acute for an inpatient psychiatrist, but is true for all kinds of physician writers. Even if the locks aren't real, there's something, their locks aren't physical. There's some binding between the physician and the patient that's always there, that I think physician writers need to be very careful and thoughtful of.
Because of the power imbalance and...
The whole gift of being a physician is that people don't come to you and ask about what kind of napkins, right?
Yeah.
They come to you with these big questions in life.
Because they want your help, not because they want you to write about them.
Correct. And because they're putting something important about their life in your hands.
Yeah.
That's a fearsome thing.
Yeah.
And it's then hard to say, can I write about that?
Yeah.
For what? For why?
Yeah.
For whom? And how can we expect the patient to answer honestly about that when in some ways some important part of our lives are in their hands? So I think part of it is thinking about how I can write even better about the lives of my patients, the people I meet as patients, and the lives of the people I meet as trainees, while being even more ethical. I intend to keep writing nonfiction as well, at least for now. But my hope is in doing so that I can continue, as I did in Progress Notes, to have people who know that I initiate a conversation where I'm going to write about them. So like the medical students in Progress Notes, these are students that normally I might have taught. But instead, I intentionally said, I'm not going to teach you.
Oh, okay.
Because I don't want to evaluate you. I don't want to be in that relationship. I don't want to be the person who's helping to decide where you're going to go in your career. So these are a different set of students than I would normally do. So in those years, I didn't teach those kinds of students. Now I can go back to teaching those kind of students because I'm not writing about them. And I think that's the kind of nonfiction I want to write in the future, which is to say that if I'm going to write about somebody, it's going to be a relationship where they know I'm going to write about them.
Yeah.
Instead of saying, I'm going to be your doctor, or I'm
sort
going
of
to
like
be
a
your
journalist.
teacher.
Like a journalist. Yeah.
Right. And to say, if I say, Professor Carlin, can I engage you? Can I write about you? That's a very different thing to say after we've developed a relationship where I'm either your professor or your physician to say that.
Yeah, that's interesting about how the relationship starts. Like if it starts as doctor-patient, then you write, versus, hey, I want to write about you right from the get-go. That's kind of interesting.
Yeah, and that may be because I'm a psychiatrist and we think a lot about boundaries.
Yeah.
So unfortunately, the physicians most likely to cross boundaries are often psychiatrists because of the nature of the work.
Yeah.
And so in psychiatry ethics, for example, we say that you can't have a relationship, a romantic relationship or a sex relationship with anybody you've ever seen as a patient, even if it's years later. And while I deeply believe that writing about somebody is not the same thing, I do think there's some real wisdom to that forbearance of saying that once the relationship is initiated as a teacher relationship or a physician relationship, it's hard for it to not always have some component of that.
Yeah. I'd be curious what you think about like I don't know how it goes currently, but I know historically like case reports have been a big thing in sort of psychiatry and sort of like how you think about that and or even in other medical specialties, even if you do a case report, just N of 1, we don't need IRB approval for that. And I know a lot of people say that, or just the standards are just all over the place for case reports and whether you need consent at all. Like if you're just going to sort of do a case report about, I don't know, something in the mouth or nose or something like that, and we take pictures and all of that. So sometimes we get consent, other times we don't get consent. But, how would you compare and contrast regular case reports, medical or psychiatric, versus this doctor writing?
Yeah, I think they're related, right? So in general, I think that you need consent, and consent ought to be a dynamic process where a person has the ability to change it over time.
Even in strict medical sort of case reports?
I do, unless the person's not recognizable to themselves or other people who know them.
Yeah.
So I've never seen an analysis of this, but my sense is that the case report really still is prominent, especially in surgical fields, where there is a fairly novel procedure. And so it's valuable to say, here was a complication of the anatomy, of the pathology, and I had to do this particular approach or procedure. So I think that's where it's still scientifically valuable. Mm-hmm. I would say that it seems to me that some of that impulse of case reports, which I look over your shoulder and I see dozens of volumes of Sigmund Freud, right, who built an entire career out of case reports.
Yeah.
Sigmund Freud's legacy at this point is in many respects more literary than it is scientific.
Right.
And I would say that one way to interpret the explosion of physician writing is that the impulse that was once scratched by case reports is now being scratched by physician writing. Mm. And if I may, in a previous conversation, you said that in the journal you edit, you get a lot of people who want to write short pieces. I think that's where that same impulse is. Mm. That sort of case report that's physician-sized, where it's really based on a clinical encounter. Mm-hmm. So it has a certain kind of real dramatic action, but not necessarily a lot of character depth, right? Mm-hmm. Mm-hmm. That's case report kind of writing.
Yeah.
There's some big action.
Yeah.
Right? That's why physician writing can translate well to the screen. But the thinness of physician writing is often that there's the action without the character development.
Interesting.
And that's what case reports have. So I think in the rest of medicine, that's where that desire for case reports has been satisfied for folks, is often in the physician writing world.
That's really interesting. Yeah. And so kind of looping back to your move towards fiction and working on the novel, that what I hear you saying, or maybe implied, tell me if this is right, is that you have an opportunity to sort of write about existential things that you sort of see in your clinical practice, but now in a new way, in a fictional way, in a way that's completely de-identified, and also ethical. Like it's not real people anymore, but you're conveying some kind of truth without harming people.
Yeah, I think if I may, I use that language of character and action.
Character and action, yeah.
Right? So that you're still having the action that is so initially entrancing when you do medical care, right? That's part of what was fun about trauma surgery back in the day, or oncology, is that big bad things happen. There's something weird about people who become doctors in the sense that they like pathology, right? Do you know what I mean?
Yeah.
There's a weird kind of doctor
Yeah.
talk that we'll have back when we're alone about really bad cases.
Yeah.
That mark us out as a little different kind of person. We like clinical action.
Uh-huh.
But as a good reader and writer, you need character. And that's what I am struggling to figure out how to do, is that I think there are limits to most of the nonfiction writing that physicians do in doing character development, at least for me.
Yeah.
And part of what appeals to me about writing fiction is that you can share some of those dramatic clinical actions while also really building out a character. You raised this question about whether or not faith and reason, theology and psychiatry can ever have a concord. And to me, part of when you think about a fully developed fictional character is that it's in part because they're looked at through multiple perspectives, right? And there's a limit to a case report. Why does case reports work in surgery still today? Because they know they're focusing on just one aspect of the person, right? They're focusing on them just as a surgical approach. But as a character in real writing, you've got to have multiple different interpretive lenses to engage them, right? And fiction allows more of them than I think the genre of nonfiction physician writing allows today.
Yeah, that's interesting. And also, your character and action sort of categories. It kind of reminds me of this critique of Marilyn McIntyre. She had this critique of narrative medicine, saying that most of medical life is not like a long story, not like a novel, not even really like a short story even, that most of medicine is sort of episodic. It's these short, dramatic encounters, and the proper genre to understand that would be the poem. You know, it's not a novel; it's a poem. You know, and so that's I thought that was kind of it. And so she thinks poetry sort of is a much more effective genre to understand medical experience, both the patients and doctors. So it's kind of interesting. Like the poem would be focused on, to use your language, would be on the action, the dramatic moment, and not a lot of character development and things like that, you know.
And the language, right, which is and the sensory detail, right, which is often remarkable in medicine, right? You get to smell things, hear things, see things you don't normally do. That's lovely. I've never heard that before. I wish, I have a sister who's a poet, a brother-in-law who's a poet. I wish I had that gift and ability. All my poems are doggerel. So I will not share them with the world. The world does not deserve that. I guess I would say that makes a lot of sense to me. And I think that is a way to think about why people wind up writing case reports or case report-like things. These shorter pieces, because they're, I think on the physician side, they're trying to make sense of this encounter that they had with somebody. And that's what, and they're trained, because they're trained to think in these short clinical episodes. They often wind up writing those shorter pieces. I guess part of why I'm compelled to write a novel, I haven't thought about this till now, is that I too mostly encounter people in one small sliver of their life when they're not really themselves, right? Or they're not the version of themselves they'd often want to present to the world. And I guess part of what you write a novel for is to have the hope that somehow you could meet a person throughout a larger scope of the arc of their life. And to have some sense of what the story's headed towards and where it might end.
Yeah, a desire for the whole story.
Yeah. And medicine doesn't have the whole story.
No.
It's not the full narration of our lives, of our bodies, of our minds. And I don't know that story as a doctor.
Yeah.
I know people on their worst day.
Yeah.
Some parts of me wants to know, are they the kind of person who likes cloth napkins or paper napkins, right? Because that's a part of who makes a compelling character.
Yeah.
Is those little fine details of how somebody sticks themselves in the world. And you often miss that in medicine.
Yeah. That's really interesting, yeah. I want to shift towards one last kind of topic about your sort of identity. You have just a huge role, sort of various administrative roles, sort of at University of Colorado School of Medicine and Denver Health. And so how do you fit these different aspects of your identity together, or writing together? How does your life as an administrator fit in, basically?
Man, little parts of me are dying inside as you call me an administrator. But it's true, right?
Yeah.
So a big portion of my life right now is working as part of a team to provide care and training. We have about 1,100 residents and about 2,000 students who come a year. That is all teamwork. There's so many people involved. I'm grateful to play a significant but small role in that. I got into that in part because I was committed to saying, look, I had this grant at the University of Chicago that changed my life. It allowed me to write a book, and I wanted to put together administrative structures that allowed other kinds of physicians similar agency and other clinicians. So I initially had become the medical director of my unit and really tried to give people some change in their work schedule so they too could pursue dreams and passion projects of their own.
Wow.
I was successful enough at that I was invited by my institution to take on a larger administrative role, and have now been doing that for 7 years. To the extent that I can, that remains my goal, is to say, look, I have been through these systems. I liked lots of things about them, but they have a ton of problems, and I want to work to make them better so that they increase the amount of agency people have. That's part of why I wrote Progress Notes, is I want to raise up systems that make people better and help them serve themselves, their families, their friends, and their patients better. Mm-hmm. I am so grateful to work in a public system, right? I work in a safety net hospital. Our job is to care for people who otherwise wouldn't receive care. So I do wear a lot of hats. Most everybody else in the system does. We work as a team. But our goal is really to say we want this to be better for people. Now, on a day-to-day basis, sometimes I just wind up answering a lot of emails and taking a lot of meetings. That's not what gives me joy, I'll be honest. But I try to take those meetings, answer those emails, if they're pursuing this larger mission that I'm working on. That'll change in life. It always does. We move around. We think differently at different times. But for me, the question isn't something like work-life balance like people talk about or wellness. It's a sense of harmony. It's a sense that what I'm working on in one aspect of my life feeds other aspects of my life, right? And so when I teach med students, it forces me to think about how to communicate something. It forces me to think about what's the state of the science, which then helps me be a better doctor. And when I continue to practice medicine, while also having an administrative role, it reminds me of all the challenges of being a clinician today, right? I choose to receive care at the same hospital where I practice, and my family does, also so that we can see what it's like. The care is great. We're grateful to receive care there, but also because it reminds us of what it is to be a patient. So for me, I made a decision early on that this is the kind of work I wanted to do. There's lots of different ways to approach it, and I'm grateful that so far I've been able to do so. It's a great thing to get to be a doctor and get a chance to write a little bit and to teach a little bit and to reflect on what it means to be alive, to fall ill, and to take care of people.
Yeah. Well, I mean, and it's been a real joy, talking with you over this hour or so. But just a consistent thread I've heard throughout your whole life is you're always concerned with some kind of individual in front of you, and then you have a concern about, well, what's the system in place that kind of led to this? So you wanted to help the individual, and then you want to affect change in the system, and then you also just tend to be really curious, it sounds like.
There's a lot to be curious about, right? I think my best days are the days I'm curious. The days I'm not curious are the days that I'm at my worst. But there's just lots of things to be curious about. I'm looking around your office, and there's so many books, and a lot of them I've read, and some of them I haven't, and I want to know what's behind their pages, right? It's hard for me not to get up while we're talking and go look through their pages. But I know I'm going to die without having read even a fraction of the world's great books, right? Or seen the world's great things, or met the world's great people. So you just have your own little life, and you try to do the best you can. And at least for me, and I think for most of us, being curious is one of the ways to do the better version of it. There's so much more to learn and see and do. So
well, it's been a real joy being with you today. Thank you, Dr. Nussbaum.
Thank you, Professor Carlin, and thanks for all the work you do at the McGovern Center and trying to instill curiosity in the next generation of physicians.